Welcome back, everyone. We continue our discussion on management of diabetes in pregnancy and clinical uptake. Let's go to the summary. Pregnancy is a state of high metabolic activity in which maintaining glucose homeostasis is of utmost importance. When hyperglycemia is detected in the pregnant mother, this is referred to as GDM, although controversy remains over diagnostic criteria. It is likely that genetic, epigenetic, and environmental factors all contribute to the development of GDM, and that the mechanisms involved are complex and advanced over a substantial period of time. However, in the majority of cases, pancreatic beta cells fail to compensate for a chronic fuel surfeit, leading to eventual insulin resistance, hyperglycemia, and an increased supply of glucose to the growing fetus. There is also evidence that adipose expandability, low-grade chronic inflammation, gluconeogenesis, oxidative stress, and placental factors contribute to the pathology of GDM. Greater understanding of these processes and their contribution to GDM is required in order to develop effective treatment and prevention strategies. This update highlights many of the controversies and knowledge gaps in the clinical care of GDM. A great need exists for high-quality clinical evidence to support many aspects of care. Two areas deserve special attention. First, adoption of the recommendations of the IADPSG for diagnosis of GDM will result in a large increase, perhaps a doubling, of the incidence of the condition. Justification exists for this approach based on the perinatal outcome from the HAPO study. Indeed, because the relationship between maternal glucose levels and perinatal complication is not steep, the additional women identified by the new criteria could have perinatal complication rates that are only slightly lower than the rates of the women diagnosed as having GDM in the past. The real problem is that even in the past, only about one-third of women with GDM incurred a perinatal complication of any sort that could be attributed to the effects of the condition. A much smaller fraction, less than 10%, incurred clinically important complications such as birth trauma or neonatal jaundice. Doubling the number of women diagnosed with GDM will at least double the number of women who have the diagnosis without real perinatal risk. Approaches based on fetal measurements hold great promise to help clinicians substratify antenatal and perinatal risk in GDM so that intensive treatment can be directed at the women with the truly high-risk pregnancies. Such approach are deserving of expanded evaluation in clinical trials. The second area deserving special attention is the heterogeneity of GDM. The review have already alluded to subtypes of GDM based on known causes of beta cell dysfunction. Even among the large majority of women who do not have autoimmunity and monogenic diabetes, considerable heterogeneity exists. Asian women tend to be leaner than many other ethnic groups, and yet they have high rates of GDM. People of African ancestry have lower GDM rates than other ethnic groups, but higher rates of diabetes mellitus after GDM. Understanding the genetic and pathophysiological underpinnings of these differences may be useful in developing more targeted approach to preventing GDM and preventing diabetes mellitus after GDM in mothers and their offspring. Now, what are the key points in this update? First, gestational diabetes mellitus is caused by reduced pancreatic beta cell function, the causes of which include the full spectrum of causes of beta cell dysfunction in young women. Second, GDM is associated with a modest increase in adverse perinatal outcomes, an increased risk of obesity in the offspring, and a high risk of post-pregnancy diabetes mellitus in mothers. Third, GDM is treated nutritionally. Intensification with insulin or oral antibiotic agents is added if maternal glucose levels and or fetal growth parameters indicate a sufficiently high risk of perinatal complications. Fourth, long-term management of mothers includes assessment of the level and type of diabetes risk, and for women at risk of type 2 diabetes mellitus, lifestyle and or pharmacological approaches. Fifth, long-term management of offspring focus on detection and mitigation of the development of obesity and its complications. And lastly, a large need exists for high-quality clinical evidence to determine optimal approaches for management of GDM during and after pregnancy. This ends our course on management of diabetes in pregnancy, clinical update.